Bob, did you want to add something there?
I would like to, for some of this debate, to take the point of view of the person who's trying to keep themselves free of HIV. And several of the comments, I think, have been very appropriate for people who are in leadership position where they might try to engineer an optimum approach to stopping the HIV epidemic. But from the point of view of people who certainly need to try to keep themselves free of HIV, the problem is often just not thinking about it enough and not realizing that there are options and being afraid of stigma. And, with regard to the comment about whether PrEP has a chance of ever being used in countries that stigmatize and criminalize sexual behavior, I would tend to agree. But the problem is not PrEP there. The problem is the laws that stigmatize and criminalize sexual behavior, anyone's sexual behavior. And one has to doubt whether there's going to be any real traction against the HIV epidemic if certain structural changes can't be made. And to be sure, we had success in doing the IPREX study in South Africa and in Ecuador, in part because these are two countries that have provided leadership in providing constitutional protections for LGBT communities. That mattered. That's why we did the study there, because we knew that people could be somewhat protected when they went out and asked for what they need. I also think that we should challenge this notion that ARVs are precious. I've heard that term often. They're not a precious natural resource. They're actually the product of human industry, and that industry can scale up manufacture as needed to meet human needs. And as manufacture increases, unit prices drop. And we applaud the fact that more and more companies have been willing to entertain and actually submit their intellectual property to the pool in a way that would facilitate the expanded manufacture of these agents. I also think that we shouldn't be trying too hard to pick which one is best. I think that all of these together promise an enormous amount of synergy. Early treatment has been policy in San Francisco for several years now. We've seen community viral load slowly decline. We've seen new infection rates decline. And yet San Francisco is also one of the places most interested in PrEP. Why? Because they know that, that many people need an extra motivation to go out and get an HIV test. They also know that 30 to 50% of new infections come from partners who are so recently infected that there hasn't been time for an HIV diagnosis or even a test, much less starting treatment. And so PrEP, I think, is a way that we can destigmatize the drugs and the disease and the infections. I also think it's a way to motivate testing, and it's a way to get us to the place where we ultimately want to be, which is zero community viral load. But I doubt early treatment alone can do that. I think we need help.
Helen, did you want to pick up on that? And then I know we have two questions from the floor, and then we'll get down to the other end.
This is just a very quick comment, but just in response to WHO and guidelines, I mean, one of the problems is that in the absence of a guideline that will come in a year, we've got to make a decision. So we're making a decision in the absence of a guideline, and so we're going to give it our best guess and apply a certain logic. But that's why I'm saying I think one of the issues that is difficult for countries are the tools to how do you prioritize. When you see the modeling, you see sort of condoms and this and that and the other. So I would say, well, how much effort should we put into condoms? How far can we go with condoms? And but there's nobody that can tell you that. So do we keep pouring condoms into the system, or is there a glass ceiling? And that we're not getting any help with. So we do not know whether to pour everything into male circumcision and say we've hit our glass ceiling with condoms, or. So one of the problems, and we always know this is a problem for WHO, is that we've got very strong data. It needs to be interpreted in some way, and we're going to be a year before we get a guideline. So at a country level, because of the pressure of the epidemic, we are going to have to take decisions in the absence of that kind of support. And I would appeal that, particularly the issue of prioritization, we need to actually really prioritize it.
Great. Mike?
Just one really quick comment. I think it's reasonable to say that with respect to decisions about pre-exposure prophylaxis versus the treatment as prevention issue, that we don't currently have an infrastructure to support pre-exposure prophylaxis. It's not just the stigma, it's the biomedical industry and the physicians that are prepared to write a prescription and have a contract with the client or the patient to see them repetitively and manage this properly. This may occur, by the way, and the CDC is working on guidelines and normative behaviors, but it doesn't exist. And it doesn't exist in the United States, to my knowledge, in most communities. It certainly doesn't exist in resource-constrained countries. So as we think about this, I think it's really critical to be realistic. I mean, that's part of this debate. What can we do now? And I think Bob and I are in a committee together to discuss this. So that I think that this is something we're discussing. What are the normative behaviors that biomedical healthcare providers have to do to give PrEP? So.
Bob is not sitting next to Mike. I see you definitely want to respond to him. And you have 20 seconds.
20 seconds. Mike, HIV clinics are calling me all the time. They want to provide PrEP. They want to provide PrEP because now that PrEP is known to be effective, they've talked to their patients about sex, sometimes for the first time ever. And sure enough, they're having sex. And they're having sex with some seronegative people, and they want to get PrEP for their partner rather than just sharing the prescription that you've already written. So patients in these clinics are telling their doctors that they want PrEP, and then the doctors are also realizing that some people are hard to retain in care. That's a problem. And part of the problem is that they're afraid to go to a clinic that only treats HIV people. And so getting some PrEP users in there who are HIV negative is a win-win for early treatment. So, this either-or argument is going to force us to fall flat on our face when we should be running.
So before I let Mike have 10 more seconds, Tony.
But it's not, you're both right. So what we've been trying to say, and this is really great that we're having, this is probably the best discussion that I've heard in the last, there is a place for an intervention. What we were trying to say, what I was trying to say yesterday, is that the beauty of the IPREX and the beauty of 052 and the beauty of the discordant couple, the Botswana couple, is that scientifically it works. It shouldn't be one pitted against each other. So if you have a situation like you have in San Francisco, where you know that now you can go to the patient and say, guess what? This works, and then figure out a way how to implement that in the same way as you're talking there. We should not be getting into a situation of one or the other. That was the purpose of the third to my last slide, which said that we have now an entire toolkit that we need to figure out how best to use.
But you have to prioritize.
Yeah, absolutely. Helen, I agree with you completely. We have to prioritize because the fact is we don't have enough resources to completely do anything we're talking about right now. So I'm not getting into the prioritization argument. I'm getting into the point that in San Francisco, in Bob's clinic, he now has a tool that he knows to work. So the city of San Francisco, with their citizens about what they're going to do, now have the scientific basis to make a decision of how they're going to prioritize. That's different of how we globally prioritize or country-wise prioritize.
Before I see questions and I want to get them, don't move. I want to turn to Steph for a minute. This issue of prioritization and making choices is critical for every donor. But I want to ask you, as one of at least 3 people I know on this panel right now who were co-authors of the Towards a New Investment Framework, trying to be smarter about the investments. And so hearing this debate on your left, it's a great article in The Lancet in June. So what do we do with that investment framework? Is it a tool that's going to help us make these prioritizations?
It certainly is a first step toward helping to think about prioritization. I mean, it's been interesting for me here at this whole conference. It reminds me a lot of being in Vancouver because we were so excited in Vancouver about the appearance of triple therapy. And here we're so excited because finally we have some good news about prevention. And what we do with that, that's what was the premise of this discussion. It seems to me we have to think very carefully about what we do with it where. So I think many of us, probably all of us, were surprised at how extraordinarily successful the appearance of antiretroviral therapy on the scene in Vancouver led to a tenfold increase in global funding for HIV, which at the same time raised funding for global health in all kinds of other areas. So one of the things that the results of this conference suggest to me is that how can we capitalize on these exciting new results to re-energize funding for international HIV/AIDS and hopefully also for global health. The tactics will be very different because this world is very different than it was post-Vancouver. But at the same time, Helen has alluded to the difficulties of prioritizing in South Africa. South Africa is the richest country on the African continent. So the prioritization discussions are much harder in other countries. And, you know, every time I hear, it doesn't have to be yours or mine, it can be both. I'm like, well, if you're the program manager in Malawi, it can't be everything, right? It is a very difficult decision. So the program manager in Malawi today is spending all the money that's available for the program. So if we're going to try to add to that portfolio the new interventions we've been talking about here, either they somehow become magically much more efficient at what they're doing and create a whole bunch of money, which I use the example of Malawi because it's already the most efficient treatment program that I know, or they stop doing a bunch of stuff that they're already doing, or somebody magically comes up with some new money. So if you're the program manager, you can't make magically money appear, so you're going to be forced to deal with the prioritization in the context of what you've got. So for me, there's a difference between the scientific evidence and what you can do with it at country level. Now, Tony is absolutely right that the efficacy is now clear. It turns out the condoms are also highly efficacious. The problem comes in the effectiveness of the condoms, right? So it turns out that while the scientific data is absolutely clear about what the efficacy of these new tools is, we still don't know about their effectiveness at population level. Now, I actually am much more optimistic about some of these tools than I am about condoms, just because they're adherence dependent in a different way. But male circumcision, for example, is not adherence dependent in the same way. And so the ability to extrapolate from the efficacy of circumcision to the effectiveness of circumcision gives me much more confidence than it does with tools that are highly adherence dependent, right? So it does become critically important for us to think now about what advice do we give countries today. For the program manager in Malawi who doesn't have new budget, what do they give up to start implementing which of these tools, right? And that, I think, is really, at the same time that we come up with new strategies to double the size of PEPFAR and increase the contributions to the Global Fund, capitalizing these wonderful results to do advocacy, but don't shy away from the very difficult prioritization decisions that are being faced by program managers in countries.